Okay, good evening, everyone. We hope that you are having a nice weekend. It is always beautiful to spend your weekends learning, and learning about medical education is one of the most important things that you would do, especially in your early years. So they say a mentor is someone who sees more talent and ability within you than you see in yourself. And that's a message to all the motivated youth who are listening to us right now. Choose the mentor to learn from them experience, and then you would see the magic of learning. And tonight we have the best mentor in medicine, Dr. Thikra Al-Wattar. Dr. Thikra is a consultant acute and respiratory medicine in Yeovil University in UK. She's a diploma in thoracic medicine from London University, and she's a Royal College of Physician educator and national and international PACES examiner. She will talk about respiratory examination. Most welcome with us, Dr. Thikra, and we are looking forward to getting inspired by you tonight. Thank you so much. The floor is yours.
Thank you very much for this lovely and very interesting introduction. Omnia and Dr. Mubarak and every one of you who participated in arranging these sessions. I cannot say more than I am very proud of you, the way you present your cases, the way you speak, the content of your speech. So carry on with this, and actually I am learning from you, and I am very happy to be part of your team. Assalamu alaikum jami'an. We start with this evening as we are talking about one of my skills as a clinician. I may find you more fluently speaking, and many of you are in research, many of you are in different basic sciences knowledge. My love is my clinical work, and I don't mind doing the work continuously, including weekends, once I am in contact with the patient. So, as I expect you to have in the future, and I am very happy that we are starting the contact with the patients at an early stage in your medical education. فمن أحسن الخطوات اللي سووها بالتعليم now إنه أدرجوا التدريب السريري بمرحلة مبكرة، لأنه كلنا نعلم إنه مثل ما يقولون practice make perfect. فأنتوا كل ما تبدون من وقت تمارسون الطريقة الصحيحة في فحص مرضاكم، كل ما راح تكون جزء من شخصيتكم، شلون راح توصلون للمريض وتفحصوه بالشكل الصحيح and in an organized way. As you know, all of you, the physical examination of any system is composed of 4 data اللي هي inspection, palpation, percussion, and auscultation. And these are the data whom we will follow in any examination, whether it is respiratory or abdomen or other things. So, if we are to talk about the inspection, of course, طبعا نحمد الله انطانا كل هالحواس حتى نوظفها لإعانتنا على تسيير أمورنا. فإحنا we have to be very clear about what we are going to do with these patients. And inspection has to include our skill to be قوي الملاحظة. We have to be very good observant. We have to have good attention. We have to have power of observation. فمن نحكي على الانسبكشن we are using our eyes. طبعا we will concentrate on the face, hands, all these things. What is the environment of the patient, whether there are any devices, inhalers, nebulizers, all these things has to be very clearly used as a clue to what is going to happen once you examine the patient. So let us go through. The exam starts, as you know all. Any exam starts from the first step. You come to see the patient, or the patient comes to see you. And before anything you do, take a moment to look around for any clue, because this is very important to have a look at the environment of what is going on. So the examination, any examination, should be focused and performed in a correct, systematic, and a professional way. So if we go to the first slide, okay, so as we said, we will look at the environment, devices, inhalers, nebulizers. Then we have to expose the patient next. How do we expose the patient? We cannot do that unless we ask the patient permission, and we have to respect their will. If they say no, we say no, but ask them first and then expose the chest. And by looking at the chest, you have to be very careful not to miss any surgical scars or other markings or the movement of the chest, and so on and so forth. So if we look at if we go to the next slide, let's see what is in the next slide. Dr. Mubarak, please. Okay. Of course, the chest wall can show itself as different shapes. So if we look at the chest wall and it is a flat chest, we may think that probably this patient had an old scarring of the lungs, therefore the lungs are not in the right volume and the chest wall shrinks. So flat chest usually indicates old chronic TB or other infection. Pigeon chest is pectus carneatum, and this is maybe related to having asthma or respiratory disease at early age, when the bones are still very soft and not hard enough, and it causes that deformity. Funnel chest is a deformity patients may born with it, so it's a congenital variation. And the barrel-shaped chest is for someone with chronic obstructive lung disease, where you see that the anteroposterior diameter is equal to the side-to-side diameter. In normal chest shape, the side-to-side diameter is much longer than the anteroposterior diameter. And the other deformity of the chest wall is due to spine deformity, kyphosis, where the bending is forward, and the scoliosis, where the spine is tilted to one of the sides. Okay, if we go to the next slide, please. These are examples of the one on the right with the like deformity on the right. It is the pectus excavatum, and the one to the right is the pigeon chest, where the sternum is bulging forward. Pectus carneatum and pectus excavatum. Next one, please. And this is, of course, it shows the way the barrel-shaped, how it presents. The kyphosis bending forward. The pectus carinatum is the pigeon chest, and the pectus excavatum is the congenital deformity, and the scoliosis is the bending of the spine to one of the sides. And barrel-shaped, as you know, that the anteroposterior diameter becomes equal or even long or bigger than the side-to-side diameter, and this indicates severe COPD disease or emphysema. Okay, next slide, please. Okay, so with regard to the okay, now if we go back to the inspection, Dr. Mubarak, please. In the inspection, first slide, before that, yeah. If we go back to the first one, I think the minute we see the patients, we have to look at their faces and we ask them if they can show us the tongue, because that will give us a big clue that the patient is not centrally cyanosed. We look at the hands and we look for important clinical signs, including clubbing of the fingers, flapping tremor. You feel the pulse and you find it whether it's sinus rhythm or depends what character, what rhythm the patient has. So you need to feel the pulse. You look in the eyes if there is any conjunctivitis or any pallor, although it is not a good site to look for pallor. You look at the tongue for cyanosis and you look at the neck for raised JVP or not. In the environment, all these things can give you a clue, including other things where you will find probably a pot of the sputum and how much phlegm in that pot and what is the color of that. All these are a clue for you to direct your examination and making the diagnosis toward that information you see. Chest wall shape, of course, as you know, some patients, especially here when the skin is very fair, sometimes even very big scars are not very easy seen and they can be missed. So you have to be very careful exposing the patient and look very carefully for any scars. And the scars of the chest can vary from midline sternotomy to side one, and sometimes they are too small to be noticed, either hidden in the axilla or at the back when there is no enough like scar tissue to indicate the surgery. And of course, once you spot that, it will direct you towards what you expect to hear and what is the way the chest wall is going to expand. And all the chest movement will be governed by what kind of surgery that patient had, either segment, like one segment removed, or lobectomy, or total pneumonectomy. And according to that, also that will reflect on next step when you do the palpation, and that will probably reflect on the position of the trachea. Okay, if we go back to the slides, we did that. Now we return back to the palpation. It's very important to use the hands, and when we use the hands in palpation, we are going to use the position of the trachea needs to be confirmed. The position of the apex is very important to locate. And then later on, the tactile vocal fremitus, which some examination, they may say you don't need to do it. But as we learned it before, it never goes away. So I always do it when I suspect there is a pathology in that area. So to feel the trachea, you need to localize it by knowing where is the sternal notch, and you can slide your finger, the middle finger, up and down to see whether you can feel the cartilage of the trachea. The trachea in general should be central, but usually it is slightly deviated to the right side. But I don't expect it to be that significant to say it is deviated to that side, unless there is pathology. And the pathology which can cause the trachea shifted to one side, it can be variable. Either there is a collapse and scarring of one side, and in that case it will be pulled towards that side, or there is large pleural effusion, or tension pneumothorax, where the trachea is usually pushed towards the opposite side. So I hope that's clear, but I am sure that once you practice and more, you will start to feel, oh, I can feel the trachea easily, whether it's deviated or not. And the photo next to it is how to feel for tactile vocal fremitus. And what is tactile vocal fremitus? It's the feeling and the perception of the vibration of the breath sound through the larynx, trachea, and the bronchi. So it's the transmission of the sounds through the larynx, trachea, and the bronchi, and it's conducted through to your feeling through the hand. And the tactile vocal fremitus is, once you trained on the normal one, you can feel that there is some increase in the tactile vocal fremitus when there is consolidation. In another word, when there is pneumonia, the tactile vocal fremitus is high, and it is much reduced in when there is a bronchial obstruction and collapse, and it is absent completely when there is massive pleural effusion. Okay, so this is the palpation. Again, in the palpation, you have to assess. Mubarak, I don't think we have a slide for the expansion of the chest. It's very important to assess in the palpation how would the chest wall expand. You should always put your hand and make a grip on both sides of the chest and ask the patient to take a deep breath in and out to see whether the thumbs, which are put very close to each other with a tag of skin, whether they expand equally to the sides when the patient takes a deeper breath in, and there is no limitation in one side against the other. So it is very important to feel for chest expansion and to be checked symmetrically. Okay, so this is the palpation. And of course, the palpation, another thing to palpate is very important when you sit the patient forward after you finish the whole examination anteriorly, and you start to feel for lymph glands, whether submental or in the neck or even supraclavicular. You have to feel for these lymph glands enlargement, which are set in the upper part of the supraclavicular, submental, even posterior occipital lymph glands enlargement. Okay, next. Okay, next. Now, percussion. Of course, now we used our eyes for the inspection. We used our hand for palpation. And again, our hands is used to assess the percussion note in any patient. So to identify the sternal notch, and then we identify the sternal angle, and that is very equal to the second intercostal space where you start your percussion note. And you will, by doing a lot of examination on normal people, you will find that when you tap for this percussion note, you will recognize the impaired percussion note when it is impaired. And of course, you can say this is hyperresonant when there is emphysema or or pneumothorax. And you may say this is a stony dullness when there is massive pleural effusion. And sometimes you say, I think the percussion note is impaired because there is consolidation. Okay, next. Oh, this should, okay, fine. If we skip that and go to the slides we added now, it's the area where we can auscultate. Dr. Mubarak, my dear, if you go back to the slide or forward the slide more. Yes, and these are the area where we examine with auscultation with the stethoscope, and we can check the lobes as they come, and we finish anteriorly. Then, of course, we go at the posterior at the end, and not to miss the axilla area, and we examine the whole area. Okay, if we return back to and of course the area, these are the lobes, but we have to percuss and we have to auscultate on supraclavicular area and infraclavicular area, in the mammary area, axillary area, and at the back. We have to assess all these notes, especially with the auscultation in the supraclavicular area, infrascapular, and interscapular area. And on each time we put the stethoscope on the patient on auscultation, in our country we have to ask them to say 44. In England, we ask them to say 99, so we can't hear them. And we are checking for vocal phragmitis. So every time we put the stethoscope on one area, after we assess the vesicular breathing, we ask them to say 44. أو ما أعرف بعد أنتوا شنو طلعتوا فد رقم الله حتى we assess the vesicular breathing or if it is impaired or not. Okay. Now, next, now Mubarak is very skilled, and now he's going to tell us what is the difference between vesicular and the bronchial breathing, and by showing or by making us listen to the sounds. Okay, vesicular breathing, where the inspiration and the expiration, the duration is a bit different. The inspiration is longer in the duration than the expiration. Let us hear it, please. And this is the normal. Okay, there is no gap between inspiration and expiration. It is continuous. So the bronchial breathing is where, and we need all to practice. Each one of you use your stethoscope and put it on your like sternal notch on the trachea. And by that way, you will know what we mean by bronchial breathing, where there is inspiration, gap, expiration. And with this, you will practice that, and then you will recognize any bronchial breathing when it is heard anywhere apart from the at the trachea, because it indicates a pathology if it is heard in the periphery of the lung, like when there is consolidation, or occasionally when there is at the top of large pleural effusion. So if we can repeat maybe the vesicular breath, and then we go to the bronchial breathing, please. Good, no gap. Now the bronchial breathing, please. So there is equal inspiration, expiration, where and a gap between the two. Okay, next. Okay, now the bronchial breathing and the vesicular breathing are normal lung on auscultation. There are abnormal breath sounds, which we mean by crackles, whether at the bases or at the area of consolidation. There is a wheeze, maybe inspiratory or expiratory wheeze, and it can be scattered all over the lungs or maybe on only one side. The stridor is another noise which can be very jerky and high-pitched, and usually it is heard when the patient takes a deeper breath in on inspiration, but it can be both ways, although it is mainly on inspiration. And then pleural rub when there is rubbing between the two layers of the pleura, visceral and the parietal, and it is very much indicative of pleurisy or on the top of pneumonia. And then, of course, the vocal resonance when someone say 99 here and 44 there, where the voice is conducted to the periphery of the lung and it is heard by the stethoscope. And of course, sometimes when there is consolidation, we ask the patient to whisper, not to say 90, 99 or 44 بصوت عالي، وإنما بهمس، يهمس يقول 44. ومن أكو consolidation, when there is consolidation, you will hear that as if the patient is whispering directly into your ear rather than through a stethoscope. فهذا اللي يسموه vocal resonance. No, it's sorry. It is shown a special name. It's called whispering petroloquy. Whispering petroloquy لأنه من اسمه إنه as if the patient is whispering into your ear. Okay, next. You may, yes. Okay, crackles. Wheeze, please. Right. Good. Pleural rub. No, Mubarak, please return back to that slide just to go through and give some examples on these sounds. If you go back to the slide before, please. Yes. So whenever you hear crackles, the crackles can be heard anywhere, but mostly the crackles are heard at the bases. And the crackles can be of different sizes. There are fine crackles, where we find them when there is fibrosis of the lung or in general interstitial lung disease, or they are medium size or large crackles where you hear them in bronchiectasis and chest infection. It is very important to demonstrate to the examiners, even if you don't talk, that you know that these crackles, if they are due to bronchiectasis or infection, due to secretions, and they may change after the patient cough out. So you have to ask the patient, can you please give me a good cough? And then you listen afterwards and you see whether these crackles change in character or disappear or remain the same. Because if they remain the same, that means there is definite interstitial lung disease or established fibrosis of the lung. Now, wheeze, of course, when you hear the wheeze, you know that there is some bronchial obstruction, and it can be either due to secretion blockage or inflammation, or maybe due to a chronic obstructive airway disease like chronic bronchitis. The stridor is very serious, and once you hear it, you have to make sure that you don't miss any local cause, because it may lead to sudden deterioration in the patient, and you have to immediately recognize it, make a diagnosis, and offer the treatment. And of course, you know, a pleural rub is due, as we said, it's due to pleurisy and pneumonia, chest infection, and that's it. Vocal resonance, we went through it. Okay, if we go more. Okay, so let me just, of course, this is a summary of what we have been discussed, but I just want to tell you something بشكل عام. In general, the physical examination usually follows taking a thorough history. Most of the time, we will be directed to perform the clinical examination in a correct and appropriate and professional way. And we may be focusing more on one system than the other. Sometimes the station is purely clinical, but you don't have the advantage of knowing what is the patient history. Where is the pain? You cannot ask any of these. You are only asked, please examine this patient respiratory system because he came with increasing shortness of breath. And you don't know anything else. And not only that, you are not even allowed to say anything apart from introduce yourself. I am a student or a doctor. This is my name. What is your name? How old are you? Will you allow me to examine you? It is very important to ask the patient consent to if he accepts you examine him or not. And you say thank you. And not only that, you ask them, please let me know if my examination caused you any pain or any embarrassment or anything. I will stop immediately. Just make them feel that you look after them in a respectful way and in a sensible way, and you are here to help them and not causing them any harm. And you need to know and learn that you are very privileged to be allowed to expose someone and examine them closely and putting your hands on their very private areas. And I want you to know, in the clinical exams, it may be a little bit different in our culture, although in my opinion مثل ما يقولون الطبيب يعني منزه إن شاء الله دائما يكون ماكو إحراج بالعلم. understand إنه يجوز ما يقبلون you expose them, but for the English exams, anywhere you go, you have to put your hands directly on the patient chest and the skin, and you should always use your stethoscope directly on the skin rather than through many layers or even one layer of clothes. It's not allowed in this exam. I understand maybe in our culture is slightly different, although I am sure if the patient gain their like trust in you, they will allow you to do the exam in a professional and in a very correct way. So as we went through that, so introduce yourself, take their names, and ask them if they allow you. And once you do all these data we looked at, you go very closely, examine the hands, examine the face, then expose them and examine all these things according to the what we said: inspection, palpation, percussion, auscultation, and you have to do it all properly. Once you know that by palpation the trachea is not in its place or there is a scar on the chest wall, the percussion skill and the data is very major aid in the assessment of the case of hyperventilation or hypoventilation or whatever pathology. So once you finish the exam, and this is very important, at the end of the exam, you have to thank the patient and you have to help the patient to dress or ask them if they need any help to sit them up in a chair. And once you finish, again, now you turn to your examiner or whoever is to assess you and present your examination summary. And you say that you examine this patient and you would like to finish your examination by checking the oxygen saturation, if possible to do peak flow meter, and if there is any time to measure the blood pressure. And also, if they may stop you to say, just hang on, we want to see what have you found, but you may say, okay, and also if the time allow me, and if I need investigations, I would very much like to have a sputum sample if there is any, and arrange for a chest x-ray and a blood test. Sometimes you don't have time to speak continuously unless they ask you. I tell you something, when you are asked to examine respiratory like a scenario or a station regarding respiratory examination, you have to perform the exam as we talked theoretically in a very correct technique. You need to practice. It doesn't come like by reading a book or yes, you may see YouTubes, a lot of the YouTubes, but you have to practice on your member of the family or your patients. Every day you make it, so it will be part of your nature. So you do the correct technique, because if you feel the wrong, if you do wrong technique, it may irritate the examiner, and you may sound that you are not practiced, and maybe you sound very hesitant, which is not nice to show that. You need to be correct, you need to be systematic, fluent, and you present your case with confidence. And then you have to tell them what are your findings. And this is very important when they say to you, okay, what did you find on your examination? You may say, my findings so and so, I found crackles at the bases, which did not change with, for example, with cough. But sometimes people don't hear anything, and they make up things, and the examiner has already assessed that patient, so they have found some clinical signs which you are failing to find. And not only that, you are making up clinical findings which are not present, and this is equally bad. You will lose marks and you will fail the exam. So please do not find the clinical signs. Don't say clinical signs you did not hear them, because if they are not there, don't make up things. Okay, then after that you present your cases. It's very important to say important negative things. So when you examine the hand, of course, in your mind, you are looking for a clubbing, you are looking for a peripheral cyanosis, for a flapping tremor, for whatever you were looking for. They are very important negative signs. If they are not there, you have to say there were no clubbing, there were no palmar erythema or flapping tremor. They are important negative clinical signs. So on the top of finding the positive clinical signs, you should mention the negative important clinical signs. And then you have to construct a suitable differential diagnosis, including, of course, you have to consider the correct diagnosis. And then they will ask you probably, so what do you think the diagnosis, this and this, what investigation you are planning to arrange? And the test should be selected in a very sensible and appropriate way, with the management plan, like, okay, I am going to do chest x-ray, meanwhile I'm going to give you this antibiotic and do so, a correct management plan. And at the end you have to ensure that the patient is treated in a very respectful way, and try not to cause any physical or emotional stress to them or any harm. Because if the patient whinge or say, sorry, you are hurting me, I think in general, this will be a very negative mark on your credit as you are performing the test. Now, in general, in the exam, I am talking about maybe even in the undergraduate. These are most of the common cases which comes in the exam. Interstitial lung disease, they bring it in the exam because there are enough evidences of the crackles, and there is a lot of information to come with it. There is a clubbing, there is maybe central cyanosis, there may be some oxygen cylinder around it. Now, with the pleural effusion, again, the clinical signs are very clear, with the stony dullness, with the diminished air entry, with the impaired percussion note, with the impaired tactile vocal affirmatus, and so on and so forth. COPD, again, because it's very common and the patient may be stable, again, the barrel shape, the cyanosis, maybe the wheeze. So these are mainly the, but many other like respiratory cases can come in the exam. Or sometimes I want you to be aware that sometimes we bring normal cases to the exam. We just say this patient has shortness of a breath. Please examine this patient respiratory system. And when you examine them, everything is right, is normal. So all what you can be is you are honest in presenting your findings, and don't make up things, and don't find the clinical signs which you did not hear and they are not there. So don't be surprised if sometimes the patient is brought to you and they have no clinical signs at all. Maybe at the end, all what I can say is the more you practice, the more you become perfect in your work. And I think that's the end of my talk. If you have any questions, we can probably talk about. Okay, Dr. Mubarak, or who is listening? Umnia, Mubarak, have we finished?
عاشت الجيش دكتورة.
Okay, I hope it was clear.
Yes, clear.
Okay.
طلاب إذا واحد عنده سؤال يقدر يسوي فيها الريس هاند أو يفتح الميوت، أو في حال إنه مثلا يقدر يدز السؤال بالشات بوكس.
ماكو أسئلة، معناها لو كلش واضح لو كلش مو واضح.
أنا أعتقد كلش واضح.
زين، لا هذا assuring.
Okay, so أقدر أني أحكي بس شغلة دكتورة؟
إيه حبيبتي طبعا.
Okay, so because this session is targeted to students, so I just want to comment on something that we as students all encounter in like introducing yourselves to patients with respiratory complaints. The most important and like tricky part is taking a history from someone who has like difficulty in breathing or coughing or something like that. I personally had such experience. I remember my one of the exams, the history mastery exams. One of the stations was in the respiratory examination. So the patient has an COPD exacerbation, and I was asked to take a history from him. And the patient was so tired, and I didn't know how to like deal with such patient and how to start the conversation. The first thing he said, عمو ترى أني تعبان حتى ما أقدر أتنفس. نبتدي أحكي. So I'm sure those students will like encounter something like that in the future. So any tips on how to open a conversation with a tired patient with respiratory complaints?
Yes, of course, Habibti. This is very important question. That's why for the exam sakes, and especially for the postgraduate, I haven't been examining undergraduate, but in general, and I am sure even it's in the undergraduate, maybe it is more needed in the undergraduate situation. We have to select the right people who can probably have enough patience to tolerate the long talking of the students, and they should know that for someone like a consultant, probably in 10 minutes time will conclude everything because they are practiced and they know what to ask. But for a student, maybe they will be lost, and one complaint might drag other complaints, which probably is not even related. So, number one, for the examiners or the mentor or the people who are responsible for this, the teaching and the examination, should select the correct and the right patients, and not to bring someone who is acutely unwell or عجزان من نفسه ما يطيق حتى نفسه. The selection of the patient is number one. Number two, the students has to be calm enough to assure the patient that they are, sorry to say, they are not guinea pig to train on them, but they are here to help them and to help themselves. And they have to ask them, I would like you to kindly help me. I am sitting the exam, so I will be my best. So be kind to the patient and treat them with respect and give them a value of what they say. يعني مثل ما يقولون تمدحها انه دا ينطيك good information، تمدحها وتقول له اشكرك لانه سمحت لي افحصك، واي وقت تشوف نفسك تعبان please let me I can stop. او مثلا تريد تشرب لك فد كمع مي او فد شيء حتى شويه ترتاح. يعني كلها هذه it counts. Psychologically we have to treat our patients like a human being, and they have مثل ما يقولون إحساس والشعور. ما يصير يعني إحنا ما جايين بس حتى نأذيهم أو نتعلم براسهم، إحنا جايين نفيدهم ونستفاد منهم طبعا دلوقتي. I think the approach is very important. دكتورة أمنية حبيبتي.
Thank you so much, Doctor. And I relate to your talk with the previous session about compassion and empathy. Yes, those soft skills are very important for students to learn, along with the theoretical knowledge and the practical skills. Those hidden parts of the curriculum are very important, and it will differentiate a good doctor and a normal or like whatever doctor else in the practice. Thank you so much for the presentation.
Thank you, حبيبتي.
Now I think no more questions.
Okay.
So far, Dr. Mubarak?
I think so. Yes, I think so. We can end the
meeting.
Yes.
شكرا دكتور مبارك مرة ثانية. I am so grateful to you. It's very colorful slide. Normally I don't opt for very colorful slides because I'm very basic in my knowledge, and it was really very good of you, and you always very distinguished team in your IT and knowledge, and I am very proud of you all.
Thanks.
Thank you so much, Dr. Thikra. It was very nice, like hearing from your experience again and again. We're looking forward to the future sessions with you. I'm certain that our listeners and participants have gained much appreciation of what you did with us during this journey. Thank you so much, and inshallah we will meet soon.
ألف شكر. تصبحون على خير كلكم عيني.
تصبحين على خير. مع السلامة.
مع السلامة. Good luck.
مع السلامة.
مع السلامة.